that, I will ask Bill Turner, who has chaired the NICE Guidelines Committee, just to give us an oversight of how these guidelines came to be and the main issues that are being dealt with. Bill.
Thanks, John. Good morning, everybody. So, just so that the actual chair doesn't feel offended, so in fact, I was the clinical lead. Professor Julia Verne, who some of you will know from Bristol, who is a public health physician, was the chair, and a very good chair at that. So I wanted just to set the scene before we hear something about the content of the guidelines from Hugh Mostafford, who will talk about non-muscle invasive bladder cancer, and Professor Robert Huddart, who will talk about muscle invasive and more advanced disease. So I have 3 slides which I will just run through. For people who aren't as familiar as they might be, NICE clinical guidelines are commissioned by NICE for the whole of the NHS in England. They may be adopted by the devolved nations, depending on what the devolved nations wish to do about that. They're done with the aid of 5 national collaborating centres, and there is a very highly structured process for the development of these guidelines. So all the various aspects that you can see in the process there are set out in a manual which is reviewed regularly. One important point just to bear in mind when you look at a NICE clinical guideline, whatever it's alluding to, is that there are 2 fundamentally different kinds of recommendation, and it takes some getting used to, it took us some getting used to, the NICE terminology. Offer, this, that or the other, in essence means that it's expected that this will be discussed and it's probably going to happen. A consider recommendation is expected to be discussed and it may happen. So briefly, we met over a period of just over 2 years, 3 urologists, 3 oncologists, 2 nurse practitioners, 2 patient representatives, pathologist, radiologist, a GP and a public health physician. I hadn't realized until I counted them recently, we actually generated 80 recommendations ranging across the whole area, from information and support through treatment of non-muscle invasive disease, muscle invasive disease, through to specialist palliative care. There were 2 economic evaluations and 16 research recommendations. And the guideline development group generated 10 key priorities for implementation and 5 key research recommendations. In other words, the clinical recommendations and the research recommendations that the group collectively thought were the most important ones. I think the other thing for us, looking at these recommendations, this bladder cancer guideline is just a little bit of compare and contrast with other bladder cancer guidelines which are out there. And the ones which I'm aware of, I've listed there. And just to highlight the difference in the way that these come about. There are no better or worse, they're just done in a different way. And I think that means that different weight is attached, or should be attached, to how the recommendations are used. And bear in mind that the only one of those which is really for a health system is the SIGN, the Scottish network, which are really for the NHS in Scotland. Others are, in essence, for urologists. So with that introduction, I'm going to hand over to Hugh Mostafford.